Hi, good morning, everyone. While we have more people continue to join the room, I just want to thank you all so much for joining us today here at the SingHealth Duke-NUS Global Health Institute Global Health Seminar Series, or GHSS. My name is Natasha. I am an Education Associate here at the GHI, and today we're delighted to host 3 emergency physicians who you'll be hearing from shortly. Before we start today's session, I would just like to remind the audience of the webinar's features. You should see a Q&A box on your Zoom bars. Please use that to let us know if you have any questions for our speakers today. We will also have some time at the end of the session where we will spend some time with the speakers in a panel discussion to answer as many of your questions as possible. Can I just check from our Zoom audience that everyone can hear me? Can you just send a reaction in the Zoom webinar? Great, thank you so much. We'll just start in just a minute. Thank you.
Hi, so good morning, everyone. So we have 3 physicians with us to share on this platform. These 3 emergency physicians are part of the group of 10 emergency care leaders who are with us from around Asia on a 1-month pre-hospital emergency care fellowship program. We are fortunate to have them share with us on this platform today. Firstly, we will hear from Dr. Maritas Heronimo from the Philippines, Dr. Pham Lim Pret from Vietnam, and finally from Dr. Felicia Ahoy-Wutun from Indonesia. Before they speak, I would briefly explain about the emergency care system. So the emergency care system consists of the pre-hospital and the hospital emergency system. To zoom in further, the pre-hospital emergency care system consists of the community, telecommunication or dispatch system, first responder system, such as a trained first aider or health post nurse, the ambulance system, and the hospital system. This system has the potential to reduce at least half of death and disability from the non-communicable diseases in developing countries. For example, in cardiac arrest, pregnancy-related emergencies, trauma, sepsis, or an infectious disease outbreak, stroke, and heart attack, the timely recognition by the community and timely good quality management by all within the chain of the system can make a difference to the outcome. Hence, there is a global priority for the emergency care system to be an essential health service. So there have been multiple calls from WHO for the health system to recognize and develop the ECS as an essential service. It may be a surprise to us from the developed countries or the high-income countries. But the reality is that emergency medicine itself is struggling to even get recognized as a specialty in some of these developing countries. Hence, multiple calls once again to recognize emergency care as an essential health service. But the reality is this. There are people who work in the ambulances, but then they are not officially called paramedics, because there's a lack of legislation on what comprises an ambulance, or there's a lack of scope of practice or lack of training for paramedics on an ambulance. Hence, there's a problem with the amount of care that we can give in the pre-hospital care setting. Furthermore, most of the funding has historically been going to the hospitals, but it has been shown, for example, in cardiac arrest, that the biggest impact is seen when care is given from the community itself. So why is this so? It's because the emergency care system is really complex and there are multiple stakeholders involved. So if we look at this frame of survival, it shows all the different contextual factors that need to be in place for the system to be effective in treating the time-sensitive conditions. The inner frame are those within the control of an organization, while the outer frame are things that need governmental support or at a health policy level. So it's important to actually hear from the people within the system itself. So hence we have the 3 different countries sharing with us on their system. Firstly, we have Dr. Maritas. She's the Chief of the Emergency Medical Service of the Bureau of Fire Protection in Philippines. She has had a passion of pre-hospital care ever since she graduated from nursing from the UERM in 2011, followed by a Doctor of Medicine in the same university. She's currently taking her Masters of Science in Public Health. Then we have Dr. Pham from Vietnam. Yeah. So we'll have Dr. Maritas go first.
So good morning, everyone. I'm Fire Senior Inspector Dr. Maritas S. Geronimo from the Bureau of Fire Protection in the Philippines. So the Philippines is an archipelago consisting of 7,640 islands. There are three major islands, the Luzon, Visayas, and Mindanao, with a land area encompassing 300,000 square kilometers and a total population of 117 million Filipinos, and approximately 13.4 million of which resides in the National Capital Region. So approximately 60% of the total land area is actually exposed to multiple hazards, and that is approximately 70% of the total population who are susceptible to the impacts of disaster. So majority of the islands of the Philippines is located actually in the Ring of Fire. So due to this, earthquakes and volcanic eruption pose a threat to the population, and approximately 18 to 20 typhoons enter the Philippine area of responsibility each year. And just for the past 3 weeks, 6 typhoons entered and devastated the country. So with this, in the 2024 World Risk Index, the Philippines ranked again first among 193 countries who are members in the United Nations. So this means that the Philippines is really at risk when it comes to disaster. So a brief history of the Philippine EMS. So the pre-colonial period, the concept of EMS was limited to traditional beliefs and traditional methods such as the ambulance by foot. Then the Spanish colonial period came. This marked a significant step forward to the development of EMS because modern Western medicine was introduced to the country. And in the American colonization after Spain, so it marked a major turning point for the EMS because modernization and standardization of the EMS system was introduced to the country. So since achieving independence in 1947, next slide. So since achieving independence in 1947, the Philippines has actually made substantial progress in the emergency services. Infrastructures were made to make sure the safety of the population. However, the emergency medical services in the Philippines is not actually fully centralized and standardized. Despite the government's effort to unify the emergency medical services, different sectors such as hospitals and ambulance providers still work independently. So there is still a drive to improve the emergency medical system. However, there is no legal mandate for the development of a pre-hospital system in the country. So local government units in the country were prompted to establish their own EMS system each through ordinances or directives only. However, a unified pre-hospital system in the national level is still desired in the country. So in 2014, the Department of Health has actually issued an administrative order showing the current EMS framework that is used in the country. So next slide. So this EMS framework revolves around the 4 concepts: emergency dispatch, emergency response and care, emergency transport, interfacility referral, and transport. So this emergency dispatch involves the arrival of resources. Emergency dispatch involves the immediate identification and prioritization of emergencies, the timely dispatch of appropriate resources, and the full coordination and full endorsement to the receiving facility. Emergency response and care is the arrival of appropriate resources at the scene and the timely initiation of appropriate intervention. Then the emergency transport is the transport of the patient to the most appropriate facility and continuous care en route to the facility. Interfacility referral and transport is actually the transfer of patient from one facility to another where the patient's needs are not seen at the receiving facility. There are also other concepts in this framework. So we have other healthcare delivery systems in the country, where there are various level of healthcare, like the barangay health stations, rural health units.
Yeah, take off.
So we have the legal framework. So this legal framework are what guides the different sectors in the EMS. So these are the operation manuals, the policies. Then the governance is actually a standardized management and standardized management and supervision at the national level. However, this framework was done in 2014. There's also the Department of Health is already in the works of revising the framework so that it will be in pattern with the WHO. So the WHO framework of emergency care system. So this shows the key concepts and processes of each component of the emergency care, such as care at the scene, care during transport, and facility-based care. Sorry, next slide. So first we have the dispatch. There are actually different numbers in the Philippines that every Filipinos can actually call depending on the area they are in. So for we have local government. Sorry. Okay.
Trying to troubleshoot the camera. Yeah.
So we have local government emergency operation centers. So each local government units have their own numbers. They can dispatch their own ambulances, the local government units, or the disaster risk reduction management ambulances, and the Bureau of Fire Protection. We have also private stakeholders who have their own number, and the non-government organizations like the Philippine Red Cross who have their number, who can dispatch their own ambulances. Then we have the 911. The national number who can dispatch the Department of Interior local government ambulances, which are the Philippine National Police, the Bureau of Fire Protection, and coordination with local government to dispatch their ambulances. Sorry, next slide. So the last August 2024, the Philippines actually launched the next generation 911. So the rolling out the next generation 911 system will eventually enable the public to text 911, send photos and videos, include real-time text, and improve the location accuracy of the callers. So now we also have the e-report. So this e-report, you can actually, through an application, send if you have no witness a crime or there is an accident. However, for the emergency medical service part, it's still in the pilot study. So there are only limited CPs that can access the emergency medical services part. Next, for the ambulances. So ambulance service in the Philippines are one of the following. Sorry, next slide. So we have from local government, next slide please. We have from local government units. So we have the disaster risk reduction management and barangay ambulances. Sorry, next. Then we have hospital ambulances, which are extension of their emergency departments. Then we also have private ambulances and non-government organization ambulances such as the Red Cross, other government ambulances from the Philippine National Police and DOH, and we also have the BFP ambulance. So the Bureau of Fire Protection actually was assigned through when then President Rodrigo Duterte signed Executive Order number 56, which states that the Bureau of Fire Protection, is the lead agency in conducting fire suppression operations and providing the public with emergency medical services. The Bureau was also empowered to respond to natural or man-made disasters and other emergencies, including medical emergencies, hazmat containment, and handling of CBR and E materials. So the Bureau, this authority was granted with the passage of Republic Act number 11589, or also known as the Act Strengthening and Modernizing the Bureau of Fire Protection. So through this act, according to this act, each city should have at least one ambulances. And the BFP should make a modernization program to enhance each personnel and acquire state-of-the-art medical equipment. So each EMS unit to be established should have an ambulance with adequate medical equipment and qualified and trained personnel. So these are our uniforms. So next. So currently we have 323 ambulances. We have fast motorcycles, such as here in Singapore, the fire motorcycle. So fast means first aid service teams. We have actually all over the Philippines, 4,044 EMS personnel, and 1,052 of which have training with EMT basic. And the rest have trainings of basic life support or emergency medical responder or just first aid. So I'll present to you our flagship program, the Kalingang Bombero. So in English, it's the care of a firefighter. So this is a mental health crisis hotline manned by our personnel who are psychometricians or psychologists. So actually, before you can be a firefighter, you should be a bachelor graduate and civil. So some graduates, we have our psychologists, psychometricians, and nurses. So they man this hotline. So what's good about this hotline compared to other mental health crisis hotline? So Kalingang Bombero, actually, for example, someone called and he's planning suicide, so that our personnel is on the line while dispatching our EMS and rescue force, so that to avoid the suicide. So next. So what are the challenges in our EMS system? So in the Universal Healthcare Law, in the Universal Healthcare Law, there's an absence of benefit package for pre-hospital care. So EMS is not stated in the Universal Healthcare Law. Then the the EMT basic or the paramedic is not yet professionalized. So majority of the EMS personnel, especially those manning the barangay ambulances, have no training at all for EMS. There's a regulation of ambulances in the Philippines, but it's not fully implemented. So there's no quality assurance for the pre-hospital care. Then there's overcrowding of our EDs. As seen here in the picture, this was taken in the Philippine General Hospital. There is already overflow to the corridors. So actually, this is majority a day-to-day basis in our country. So then we have the 911. Again, I presented to you a while ago. We have different numbers. So the 911 is actually already in the talks with the different local government units to standardize the number with the 911. The problem is they're having problems with the infrastructure, the technology on how to make sure that, because since we're an archipelago, you might call 911, those in the Visayas or the farther provinces might answer the call. So they're having problems with the technology, the infrastructure, so they're still working on it. I hope in the near future, it will be already complete so that there's already a standardized number. So the problem is we still don't have a standard operation. Actually, we have an operation manual. We're in the Bureau of Fire Protection, but we're already in the works of revising it. However, there is no, we don't have a clinical practice guideline. So we're still in the process of where we will have to do it still. Next, the traffic congestion is in the Philippines is just like in Thailand and Vietnam, but there are already ways what that was done to improve if there's an emergency. So, and this is one of the major highways in the Philippines. As you can see, there is a bus lane. Actually, majority. There are few who use this just to reach your destination fast, but majority follows it. No one should use the bus lane except for buses and emergency ambulances only. So they are the ones who can only use this bus lane. So this actually helps to improve the response time and bringing the patient from the scene to the facility. Next is, of course, resources. We lack still the manpower. Of course, as you have seen, we are an archipelago. We have so many Filipinos living in the country. And of course, our equipments are not state of the art. So I'll focus on just two challenges. We have an ambulance regulation, the Administrative Order number 2018. So this ambulance regulation actually states what equipment should be inside a type 1 and a type 2 ambulances. So type 1 is the basic, type 2 is the advanced. The type 1 and this administrative order states what type of training should the personnel have for each ambulances, for the basic and the advanced. However, this administrative order is not fully implemented. So the implementation and the monitoring is not really implemented. Majority of the ambulances, almost all ambulances in the local government units and even in our Bureau of Fire Protection are not licensed by the Department of Health. So the DOH is already revising this administrative order, so it will be implemented by early next year. They are already talking with us and other local government units to help us with the licensing. But the problem is, of course, our equipments can't meet the criteria of this administrative order. So I think we'll have a hard time licensing it. Next, for the training. So the usual training you can see in the Philippines is the EMT basic. So EMT basic, usually they can have this training within their department or accredited training centers. However, the curriculum is not standardized. So it depends per institution. Then we have the emergency medical responder. All firefighters actually undergo the EMR. Then we have BLS. All firefighters are also trained with BLS. Then some EMS personnel trained with advanced cardiac life support. Then the first aid. We have vocational courses for EMT basic that is given by the government. So we're gearing towards to have all EMT basic be trained by by TESDA, which is the governing body for the vocational courses. Then we have some are also trained with PHTLS. So that's all. Thank you.
Thank you very much, Dr. Maritas. Next, we'll have Dr. Pham, who's an emergency doctor and with Masters in Public Health in Vietnam. He's also the Deputy Head of General Planning Department of the 115 Emergency Center at Ho Chi Minh City. Dr. Pham, over to you, please.
Hi, good morning, everyone. It's an
Sorry. I don't know.
Just give us a minute as we put up the slides.
Hold on, can I have the quick?
So it's an honor to be here to talk about the emergency care system in Vietnam, especially in behavioral care. So there are some content I will talk today. So the first overview of pre-hospital emergency system in Vietnam, and some challenges in developing this system, also priority management in pre-hospital emergency system, and some key challenges in priority management. And the last one is the impact of policy on pre-hospital emergency developments. So Next start with an overview in Vietnam emergency system. Operate three separate number: 113 for police, 114 for fire and rescue, 115 for an ambulance. So what happened in theory? This great communication, because when the citizen call the wrong number, maybe they need an ambulance, but they call 114. So in most of the area, the contractor guy caller to the right number. So in Ho Chi Minh City, however advanced system, no need to hang up. The contractor will transfer directly to the right number. So hospital care system, Vietnam have a 63 province. As managed hospital care center, but actually we just have 18 hospital emergency center in around Vietnam. So it's one province. This means a lot of province don't have a hospital care system. So in this circumstance, the MOS release a regulation require all general hospital or province have a hospital emergency team, but with sometimes actually it's still on the paper, not in real life. So as you can see on the map, the red dot belong to government and the white and blue dot belong to private hospital, 4 belong to private, and the 14 belong to government. So let's talk closer look at Ho Chi Minh City. This okay, Ho Chi Minh City is south of Vietnam. Our system considers two components. Just serve 30% of the city demand. Daily we serve 150 and 160 case. We have two components. The first component is about the pre-hospital emergency center. The workforce. We have a nurse, doctor, basic healthcare personnel, driver. We also have a 9 to 12 ambulance run per day. And in the EOC, we have 40 people, but 10 people per shift. Nurse, doctor, just office time. About the funding, 90% comes from the local government and 5% come from the patient fee. About subsidized station, we have 42, some of which belong to private hospitals. Just general hospital can turn our system on material workforce belong to hospital. Funding 90% come from hospital and 5% come from the patient fee. I usually for my system is a mixed operation because we have one independent center of the hospital and we also pay on the hospital. So as you can see on the map, below map, the red dot is located satellite station. Most of them concentrate on the center of city because of maybe 80% of the people living here. So it's some characteristics about the social demographics in Ho Chi Minh City. I think the area maybe 3.8 time in the Singapore main area, but the population 11 million people living here and the health characteristics we have 129 hospitals, more than 8,000 private clinics. And we have also one pre-hospital emergency center and 42 subsidized stations. And this is a brief history of our pre-hospital emergency center. In 2014, we estimate from the pre-hospital department of Trung Vương Hospital. At that time, we just 4 ambulances. After 1 year, we realized we can serve maybe million people with ambulance, so we have to transition our system to hybrid model. We also pay on the hospital. We also run separate center. From 2015 to 2018, we focus on expand our supply network. By 2019, we almost have a 32 emergency station. In 2019, we have some of my time. We have a new uniform. We have AOC operate independently. After COVID-19 from 2020 and 2022, the COVID told us a crucial lesson about we want to focus, we want to develop the system, we have to focus on our quality management. So what happened when someone called for an ambulance in our city? When someone called just for one file and in the call center pick up the phone and dispatch the ambulance and instruct the bystander to do some first aid, and when care and transfer the patient to hospital. At the hospital, we hand over with verbal and written report, and then put all the information in the computer. So it's a time like maybe 3 or 5 minutes for contactor to get the information by the caller, 15 minutes to 20 minutes to ambulance to access the scene, and 30 minutes to transfer the patient to hospital. But sometimes it happens this way. The police, the traffic police bring the victim, the victim to hospital by his hand or by on capital. He think about maybe the ambulance not arrive on time or something never haven't arrived. Sometimes we use personal phone to guide the bystander to do some first aid like CPR or something. We know that we don't have the proper software to do this. These are some challenges and solutions have been invented. You can say about we know about the chain of survival, the community possible. Not many people know about the overtime. Maybe the population awareness of how important the hospital emergency system, especially medical staff. Also, some of them also know an awareness. And not many people training about the first aid and willing to do first aid for victims. In this circumstance, we also invented we put more information in the in national media. We educate the student, teacher, worker, police. Every year, we teach them about how important of the hospital emergency system, how important of the ambulance in some cases. About the telecommunication, first responder ambulance system, we also have some challenges. About the ambulance, we don't have a quality management system. We no stick, no standard about the ambulance. So, and also we did some regulation about the national standard ambulance. The new health law also have a permit. We also developed some protocol in AOC or in the field worker for them easy to do. The hospital system, we rely about the connection between the hospital and our hospital, so that we also organize some conference, webinar, workshop to bring them together to share which they have to face, which have to focus, and make everybody understand each other. So why do we care about the quality management in now? So because we want to go faster but sustainable, and with the limited resources, by identify the which link chain of survival, and then we can target the service area for intervention. This is some of things we have done in last 2 years. About the key performance indicator, we built the indicator for pre-hospital system, and then we report and track every monthly and quarterly and yearly. And by this way, I can identify the weakness link of the chain of survival. We also will about the develop a protocol in LC on in-field worker, and we also concerned about the patient experience survey. We will somewhat confident to connect the feedback from the receiving hospital, the training, workforce. We training about BLS, ACLS, ITLS for worker, and also we training the first aid for rival and community. These are challenges in quarantine management. I try to compare them four domains. First domain of community government. I think the community government's attention is very important, because if we have attention of leadership, the community we have money, but also culture, organizational education is also very important. The second domain about the book, I think motivation of worker very important, because the worker don't want to change. So when we focus on quarantine management, it means a lot of things to intervention. So worker is very important. And about policy, sometimes policy not suit with our conditions. The synthesis of whole system is very important. The process applying intervention we also, and the last one about the complexity of quarantine management. There are a lot of things to do when we want to investigate something. It involves many people. All steps in process are involving, and the connection between the pre-hospital and hospital worker is also very important. So the policy affecting quarantine management, the Ministry of Health regulate are mandatory, but sometimes they don't always align with our demand, because policy and to create a uniform nationwide. But Ho Chi Minh City is largest city in Vietnam, so have more resources than differ from those remote working. So in this we have to need to seek approval of pilot program that the VA from standard policy. For field not cover official regulation, we also need a pilot approval. Sometimes the process to get the permission is very take a long time and take a lot of resources to get the permission. In Vietnam, we don't have OPEC in Singapore. So with our centralized government department of hospital care, so it's developed independently. So sometimes it's similar or different, direct from each other. However, when MOH release regulation, some intervention resource may no longer applicable. Even if benefits or not benefit a certain center. But fortunately nowadays the MOH have made significant change, because they need some regulation, they send them to us for feedback, for comment, and then they organize some online meeting and get the consensus among the manager and frontline worker. So in my point of view, I want to conclude that pre-hospital emergency system in Vietnam have not developed to meet the demand of the people, developed between the regions equally, and our government and community are paying more attention to pre-hospital emergency care nowadays. Developing pre-hospital emergency center require attention, quality, and the quarantine management is difficult stuff. There are not anything to do, and government policy greatly influence the quarantine management and the develop of pre-hospital emergency care. So that's all I want to talk with everyone here. Thank you.
Thank you very much, Dr. Pham. So next we have Dr. Felicia, who is an emergency physician working in Nusa Tenggara Barat, Indonesia, where she dedicates herself to emergency care. She's also doing pre-hospital emergency care, especially in international events, often responding to medical emergencies in challenging conditions. Over to you, Dr. Felicia.
Okay, thank you, Dr. Gayatri. Hi, my name is Dr. Felicia. Hello, everyone, and I would like to present about Indonesia EMS and the public Wi-Fi. So it's Indonesian. I would like to talk about Indonesians a bit because Indonesian is an archipelagic country which is extending about 5,120 kilometers from east to west and 1,760 kilometers from north to east, which is we are now considered to be the largest archipelagic country in the world with 17,500 islands. So as we know in the map above, we have the map of volcanic mountains around Indonesia. So we can see there from east to west, we all have around 130 mountains volcanic eruptions in Indonesia. And the map below is which one is the highest one. So you can see from the legend down there, the very high is called with the red line. So it's from around Sumatra to Papua in the west side. It's all prone to the disaster. And also we have also experienced now flooding and landslide due to our positions about in the major tectonic plates. Okay, so why our archipelagic country and the government decided to build an EMS in Indonesia in 2016? Because we need to first disaster, also improving access and quality of emergency service. We also accelerate response time for emergency patient and reduce mortality and disability rate. So this is the regulations in Indonesia. We are founded in 2016 by the Ministry of Health, number 19, about the EMS system. But then after 2016, we are now launched the guidelines of the book behind in the picture. In the technical manual in 2024 in October. What is the book inside? The book inside are explaining a regulation in 2016. Yes, we took very long time to have this technical manual. So the book just implements. So we are now trying to implement around Indonesia about the system of EMS. So this is the framework that may be same with the Philippines slide as well. We are taking that. You can see there is a WHO, and the other logo is our Ministry of Health logo. This is the emergency medical system, the framework that we've taken up and adapted to Indonesia as well. So we are simplified into our public safety care. This is like if there's emergency or non-emergency accident, they will call community to call this call center. Call center will be some local number or the number of 119. 119 is our national number for ambulance. So it will call the call center and refers to the ambulance to go directly to the locations. And if we need a police, firefighter, or others like a search and rescue, they will call from the call center to call them because our number is not a unified number yet. After the ambulance come to the locations, there will be a BLS ambulance. We don't have a EMT or paramedic, so we have nurse and doctors in the ambulance, depends on the case. The ambulance will bring the patients directly to the hospital river and then back to the base. So we have a common level that were made by our government. We start from National Command Center, NCC. It will located in Jakarta, and there's only one because it's under directly for the Ministry of Health. And there is directly for NCC to PSC Public Safety Center that are spread around the Indonesia into a regions. Our regions is around 500 plus regions in Indonesia, but PSC is only 365. So we are left of around 160 regions that we have no PSC in Indonesia. So in the book in launch in 2024, finally they found that they have to provide the province command center for each province. We have 38 provinces nowadays in Indonesia. So province need to have 38. Unfortunately, province command center only in my locations, Nusa Tenggara. There's only one. So any other province doesn't have the province command center. So the book that we launched in 2024 are making the province command center to be available in every province in Indonesia. So this is our command level, which is the slide in Jakarta, and the province command center only one in Nusa Tenggara Barat. And this is the public safety center. We have around 365 or 300. We cannot accommodate all in this slide, but it's like this. But there can see that some of them in Papua, in the website, not all have the PSC yet. Some of them in Kalimantan also not, it's quite big, near to Brunei and Borneo in Malaysia. We don't have much PSC on there. Also in around, the mostly severe is the East one. So the function of the National Command Center only to control emergency service at the national level, while the PCC is become like representative of NCC in the region, province level. So the PSC gonna be the managing health crisis on healthcare service. So if there's any emergency care like trauma or non-trauma, the PSC is the one who will taking care of the patients and every care. But if there is no any PCC, PSC or around that area, PCC will take over the PSC works. So yeah, so you can see the NCC and PSC mostly like regulation, coordination, monitoring, analysis information. But the PSC most like receive emergency calls that refer from 119 or local number, the first aid instruction, provide emergency medical services, and the information about healthcare facilities, also affected patients to the nearest and referral systems. This is our hub and spoke model for referral system. And we already tried in the that below. This one. This is East of Java. And it's gonna be like this. Yeah. So the red one is the hub. The hub is the hospital with the type A or our Indonesia has 4 types. The highest one is the type A and type B. So it's all is public hospital. The public hospital is the red one. It's our hub one, is with the advanced treatment, while the other one with the gray one is more like with advanced hospital data. That's why they are need to revert to the red one. So with additional information, because we are also as really prone to disaster. So the public safety center, also as a part of the medical service cluster, they are decided in this 2024 from the Ministry of Health. So any event of health crisis emergency, the public safety center can become part of the emergency medical team for the disaster. So we are going to the EMS challenge in Indonesia. So we have a lot. This is part of it. One, the very problem is we have no any one access number to emergency. We only have one number, 119. It's nationally number only for ambulance, but not for the firefighter or police. Also, we have a lack of community awareness, connecting with our culture as well, lack of public education as well. And also because we have a big country with different geographical teams, so our PSC in every region is different in human resource and equipment. Also, number 4 is geographical and language barrier lead to different type of EMS in Indonesia, because we are most island, sea. We have a boat, EMS boat, but not every place has EMS boat. Even in my place, there is a boat, touristic place called Kilis. We don't have an ambulance boat there. Sorry, and this is also it's about the funding from Indonesian governments that also in other plots. And our population is growing rate is 1.13% in 2023 and projected to reach 324 million by 2045. Also, the guideline and regulation for ambulance, which is just get out in 2024 October, it's not implemented yet in anywhere. It's in 1 month, and we haven't heard any progress yet. We have a remote islands that have limited access to health facilities, medicine, and medical personnel. And maybe this is the one, we don't have a special standard education for nurses and doctors to work in. So we start with 1, you know that from the chain of survival, number 1 is activation of emergency response. With we need 1 number to activate activate the emergency response. Unfortunately, like I said, we have the local number by every PSC. We have a language barrier, also the geographical, start with the network, signal, phone network, that's something is a problem as well. So because of the lack of awareness, the community, we have delayed occupation of emergency service because they don't know where to go, who to care. So the evaluation of monitoring from the government is not established yet. So we have around 514 agency, 365 agency with PSC in Indonesia, and we also have over 700 language traditional language, not only Indonesian language. So even in my place, we have other called Sasak, and I don't even understand that because it's a really traditional language. Also, 119 in Indonesia is not recognized as only as an EMS national number, but not as police or So this is you can see this one is my hospital number. You can see there is a 119 in here, but we have our sorry today, but we have our own number. You can see there's emergency call here. It's a free of toll. But if you want to consult this one is the other hospital in Java Island. See, hotline, ambulance, and ER, different number. Even they don't put any 119. This one is the other hospital in Mataram. Even the number is not even there. This one in Dompu is area in around next to Nusa Tenggara Barat. 119 above, and they have a two number difference. This is a private hospital in lot have branches around Indonesia. See, even 118, not even 119. It's in Java. PSC only 119. So if anyone who doesn't know, not community who doesn't know, is not having a medical background, they won't know what is PSC 119 actually. They know just call this one, 24 hours ambulance free. So, and then also we have a informatic ministry getting this 112. So our Ministry of Health getting 119, and the Ministry of Digital Information getting 112. So yeah, we have two different national number, 112 and 119, and our local number. So that is a big problem for us. So this is the improvement that we can do. Now we have the Ministry of Health making this one. National emergency number, but it's in stakeholder level, which is they need to talk about with the police, firefighters, also with the Ministry of Informatics about the 112 numbers. And also they finally, this one is not applicable yet, so they make this Satu Sehat application. This one is Satu Sehat application. It's on my phone, and maybe I'll show you a bit. It's like this. So everyone or medical doctor has to have this. They are not put this on our home, but they put this on our profile. There's you press the emergency numbers like this. So it's not directly you press the number and they directly you to 119. No, they directly you to another choose. So yeah, maybe the third number that we can do but now integration number of local PSC number with national systems. And collaboration with the telecom providers. Also, the last one is community public education through Instagram, X, or TikTok. So we go into geographical and language barrier in Indonesia. As we said before, the language barrier is around 700 traditional language. And this is our geographical barriers, which is number one, I see it also in Dr. Marita's slide. They have the special line for bus. It's a special line for bus. It's in Jakarta. You can see both of side. This is that, and that side is full. It's Jakarta in the peak time. So actually, this one is a car and motorcycle. This one is only for the bus. We call it bus lanes. Also, the bus lanes or police or firefighters or ambulance go here. But unfortunately, we say they want to be fast, but it ended not fast at all because everyone's scamming here. So if there is sometimes the police doing the police in here and they will jump up from here to go up. So this is the problem in Jakarta. We have too much people down there, and there's dense populations. And if there's ambulance, as my experience before, if there's any ambulance down here, it's really got stuck. Yeah, it's really get stuck. And we need help from the motorcycle to open the gate. And it takes time. So number 2 picture is Indonesian rural village. If you have been to Indonesian, some of our part is still like this. And it will be take around 2 hours or maybe 3 hours from the city with the rice fields around. They have a really good nature, but around here, we don't have a PSC. We only have a public health center, like community health center, with a very lack of equipment or even the very standard ambulance. So if you have an accident in here, they will take around 2 hours or more than 3 hours to take you to the city. Like my cases in Indonesia, in Mataram, the most rural area, we need to take around 2 or 3 hours. Depends on to bring to my hospital in the city. Also, some of the roads be like here. So mostly ambulance cannot go out. And sometimes we use a traditional cart with horses. If the ambulance go here, they will get stuck. So we are going to another chains. Now we are going to high quality CPR. The geographical barrier is hard to go to other because we have laws. We don't. Not every province has this PLS community education. It's just only around Java or in my place in most of the world. So there is a lack of widespread CPR training and education. And like I said, who wants to go for 3 hours, 4 hours to teach CPR every month? I'm not sure we can do that. So also the language barrier, CPR training materials might not be available in local languages, especially in rural area. They are not speaking Indonesian. They are speaking their local language. Number 3 is defibrillation chain, which is AED. AED is still expensive. For the rural area, it's not number 1 to get by. They need to fix their ambulance and the equipments, but not for the AED. But actually, it's important. Unfortunately, the funding is not enough for the AED. So it's not widely available in public place. Maybe if you go to Jakarta as our capital, yes, there is. Not all kind of Jakarta, but mostly in airport, in hospital, yes. But in rural area, underserved regions, even in my city, we don't have much, even very limited. Also, the limited number of trained personnel who can use AED because they are never trained. They are just trained by PLS. Also, we don't have any location of AED in public. So you can see in the picture here, the Indonesia is a lot of 652 language. In every province, they have their own language. So we go for the advanced resuscitations. As we know, Indonesians are equipped the ambulance with nurses and doctors. We don't have paramedic school. We don't have EMT schools. So yes, we have sometimes we don't have a short of trained emergency medical. So basically, nurse or doctor are quite reluctant to work in the ambulance hospitals. And also some of ambulance in rural area may be underfunded or lack of necessary infrastructure. And also the problems is we are back to geographic and infrastructure challenges as well in reaching patients, especially in Indonesia. Maybe the resistance as well, the miscommunications can delay treatment because sometimes even as a doctor I work there, I'm Indonesian, I speak Indonesian, and they actually doesn't understand me speak Indonesian. I need to ask my nurse or my doctor who are really local to the area and then to talk about to the patients to understand what's the patient's history. Also, we have a post-clinical rest. We know that limited of specialist hospitals in rural area. We only have community healthcare and we have no hospitals. Type A, we need from the rural area takes 2 hours, 3 hours to go. So maybe this is the kind of improvement, which is infrastructure, both ambulance first, and then maybe in the next feature, helicopter, enhanced call network with the telephone provider for all province without any problem with signaling and the maximized use of 9111. We can do telemedicine as well, and then dense area like Jakarta. The busway need to be, the regulations need to be made by the government as well, and the motorcycle ambulance, also the community police-based solution to traffic control if there is any traffic. The language barrier, language training, or taking your local nurses and doctors to be work as you and your teams. Terminology in medical emergency base, yes, we can do, but not in our culture, but should only in Indonesia, and we also communicate educations in Indonesian language or sometimes mixed with their local language. So the conclusion is we are face significant challenge in geographic, economic, language, infrastructure context, while there's a good implement by the government to go with the guidebooks. Unfortunately, it needs to be implemented and monitoring and evaluations by the government to see if it's useful for us in Indonesia. So it really constructive work from the government, NGO, and healthcare sector to improve emergency care system in Indonesia. Thank you.
So thank you very much, Dr. Felicia. So we have some questions from from our audience. I think the first one's directed to Dr. Felicia. So it's by Dr. YY Ng. Does the PCC or NCC set guidelines for your dispatch practice, or does every PSC write their own?
So NCC is under the Ministry of Health. The Ministry of Health are guidelines via the book. The book that launched in 2024 October is the guidelines for all PSC and PCC need to do, because in that book there are guidelines about what PCC need, what PSC needs. And actually the guidelines is represented from 2016 regulation. So now we are only on the book. I don't have any other regulations by now, but we need to monitor and evaluate yet. And so we don't have any other technical guide, instead only the guide that we launched last October.
Right. Thank you. The other question that we have is that either one of you can answer, but how do you decide which emergency service, whether it's a basic life support team versus advanced life support team, to dispatch after you receive a phone call?
Actually, for us in the Philippines, almost all our ambulances are just basic. So mostly the advanced ambulances are with the private. So when the 911 or the local government dispatch, it's all basic. Local government units, ambulances are also all basic. So it's the decision is just really dispatch whoever is available.
Okay. How about you?
So in Vietnam, like I said, we don't have a first responder system. So all the cases in the market we start an ambulance. So in that years, MOS also released a regulation about the standard ambulance. So most standard ambulance just have one of standard ambulance. So everyone just put in ambulance and then. But we also have some kind of workforce. We have nurse, basic healthcare personnel and doctor. So some of the cases just might have we have some criteria for some when we receive information about for example, like our hospital cardiac arrest, we will dispatch the ambulance to the doctor with some of my just compression machine or something like that, and have the doctor can kill the patient properly. Just in my center, because we don't have defect in Singapore, so we have to do our own.
And we have another one more question about how the emergency system is addressing increasingly frequent climate change impacts, such as floods, typhoons, rising temperatures. How are we coping with it?
For us in the Filipino Bureau of Fire Protection, since we are the one mandated for the disaster,
So usually, since there are so many floods, especially for the past 3 weeks, our special rescue force, we have boats, we have that will rescue or evacuate majority of the those affected by floods. Then the EMS will be on standby at the area where it is safe. If there is a need to bring the patient to hospital. But the in our part in the Philippines, what is good is the preparation, this disaster preparation. So when there is there's a typhoon, so the media or the local government will announce that there's a possible flooding. So majority of the population will evacuate to a higher place or in the evacuation centers where they know already where are the evacuation centers. So mostly we evacuated, the Bureau of Fire Protection will rescue just minimal people. It's not that many who stays in their house. So that's what's good in our country is the disaster preparation. We already know what to do. So with regards to the emergency, so if we work hand, the EMS part and the special rescue force really works hand in hand. They rescue, we wait if there's a need to evacuate to when you need to go to the hospital or needs first aid on scene.
So as you need my slide that the public safety center when they are part of medical health, so if there's any disaster, so we will be there, the PCC will be takes over from the PSC in that area. So they will call them to working with the search and rescue police and firefighter to do that. And we are just in a medical site. The medical staff and ambulance around together, getting them the shift from the medical director in the BCC. Will communicated with firefighter, police, and search and rescue. So they are only working usually in the evacuation space, not evacuations all the patients, but evacuation patients that they need from the SAR found evacuation or the police found the patient and they will take it to the evacuation tanks. But they are not working directly, just taking the patients without the help of the SAR or the guide of the SAR or the police or firefighter. So we are only just in medical.
Right. Thank you very much. So one more question directed again at Indonesia, Dr. Felicia, is about, so given that 40% of your population lives in rural areas, but only 5% of the country's healthcare facilities are situated there, in cases where the emergency service response time is too long, what is currently being done to help the patient in the meantime? Like, are you all able to give first aid instructions over the phone or, what?
Well, one of the problem is because we have to really be with some of our areas are not available, like also the phone signal is not good. So if we can do this like 3 hours to evacuate someone from the place that's like referral case with that, we are communicating with the community health center. Community health center probably doesn't have advanced ambulance. They usually only have transport ambulance and doctor or nurse, community nurse. So we contact with the nearest community ambulance or nearest community doctor or nurse around there to help evacuate the patients with this. Because we cannot send our ambulance directly to go to the place for 2 hours or 3 hours and then back to the city. It will take 4 hours. So we find the maps and the data from our community health center, which one is the nearest to the patients, and we do the help. We ask for the nurse. But sometimes there's only a nurse. Still like doctors.
Okay, so is that where you say that in some of the muddy paths, for example, you get the horses on the cart and actually transport the patients?
Yeah, sometimes
there's a nurse on there.
sometimes our culture as well are not calling the our culture is like if someone has a cardiac arrest, they said it's a natural. So they're not looking for the EMS. They're just like, oh, it's natural. It's not no need to. But if you are educated or something, just maybe the grandchildren come from the city, educated, they will need for help and then they go for EMS.
Mm.
So mostly of our patients come to the hospital, not directly by ambulance like in here. They are just walking in. Sometimes they are with the truck, with the open space in the truck, they bring the patients or with the push chart in the area. So yeah, we are looking to work with community health center, but we have the data of them.
Mhm.
But yeah, not all the PSC has, we have the data, or not even the rural area has, we have still like 150 PSC. So yeah, we need to fix that on infrastructures. Now, as in my place in Lombok, we have the data of community health center and we call them in the newest region to prepare the transportation to hospital or the newest hospital.
Hmm. Right. So actually this leads, your answer ties in very nicely with one of the questions we have about culture, right? So as we showed in the chain frame of survival, some of the contextual situation actually affects the implementation of many of the health policies. So I'm wondering if one of you could share an example of a cultural nuance within your emergency system, which a foreigner may be surprised by. So like Dr. Felicia has shared about how, the cultural view of death. So cardiac arrest is seen as, natural process. How about in Vietnam or Philippines? Is there any cultural nuance that would surprise a foreigner?
For the Philippines, I think since our culture is uh well, the Americans colonized us for a long time as well. So the effect in our culture with the Western is actually you can really see it in our country. So the use of the ambulances are really open. I mean, the idea of it is not rejected by the population. However, I guess culture-wise, since the Philippines is a developing country, so the most foreigners who use the ambulances are shocked with the type of ambulance that we have, the equipments, the lack of equipments. Some foreigners will be shocked with the status of the ambulances. So, and of course, since we are just a basic type of ambulance, we are just load and go. So usually we will just take the patient to the hospital for the treatment to be there, unlike with other foreign countries. So with culture-wise, there are some superstitions when it comes to emergencies, like in Indonesia. There are some parts of the country, especially the indigenous ones, who believe that if you have a heart attack, it's God's will. And especially we are really the religion in the country is really strong, which is Catholics. But for those who are indigenous, it's just a normal process. So sometimes they will not bring the patient to the hospital because for them it's like you will be closer to God if that happens.
Yes, thank you.
So I think in Ho Chi Minh City, Vietnam also, most of people in there belong to King Chapel, or most of them belong to Catholic or Buddhism. So it's about not like some people living as a Midwestern area. We every time, every day, my parents told me you have to have each other, have to our community. So when maybe for example, in our community, I think about the people and awareness about how to help the people. For example, my operating call center, before I implement the PCPR, maybe 20% bystander do CPR for the victim. But after 3 months, I implement PCPR where the code, just a code, not severe code, maybe 90% the bystander willing to do CPR. So I think in Vietnam, it's about it's about the willing do process, but some people don't know how to have to each other. I think Vietnam is so quite different from the South Asian, but I hope in the near futures or long term, maybe we have to train our community to how to do the right thing. As you can see on my slide, the police, traffic policemen want to have a big team, but have the wrong one. So we just train the community to have each other in the one way. I think with them, we have to focus it.
I would also like to add that, in the Indonesia, the Philippines has so many dialects. So if the foreigner will learn how to speak in Filipino or Tagalog, when he goes to another province, he will be shocked that when he speaks some words in Tagalog, that the person in that specific place will not understand because that person speaks a different dialect. So if there's an emergency, the language barrier is also still there, even if you know Tagalog. So the foreigners will be shocked that English will be the their mode of communication instead of Tagalog. So that's also
Thank you very much. And I guess that ties in with the issue of having a universal access number, which is very common in the Western developed world, probably because all of us speak English, and that makes it easier for the implementation of a single emergency number. But like what you guys have shared, that having a single emergency number is there on paper as a policy, right? But then it's not actually being practiced by the people on the ground for different reasons. Also, and that can affect the standards and quality of care that the pre-hospital system can provide. Great. Maybe we can check from our audience here if there are any questions that you would like to ask our speakers.
Yeah, so I have a question for all of you, which is, what can the international community do to help you to build and develop EMS in your own country? And so, for example, Dr. Gaya and I came back from Geneva, and there is now increased recognition of the importance of emergency kind of care, but which was not there 5 years ago. So there are various initiatives like you might have heard of the WHO Basic Emergency Care Training Program, which aims to train kind of BLS or basic level EMS providers. There's a new package called the Community First Responder Training. They've also tried to do things like start some basic data collection for trauma or for emergency kind of medical cases, right? And data, as you know, in most of our systems is a big problem, right? So my question is, what can the international community do? What help do you need? What do you think would be helpful, from your own perspective?
Actually, the first thing the international community like Singapore can organize more the follow-ups like this, like
Training.
follow-ups like this training. And the second thing I think about when I come to Singapore, I do some hospital. Maybe it's might be open my mind. A lot of things here I haven't seen before. So only me can say is I think it's very hard for myself to change our system. So I have to change our mindset of my colleagues, is my boss, and also higher boss, the health department. So I think the first thing you can say more and more, and we can organize some more and more fellowship like this for a lot of people can come. And the third about most of countries, South Asian and some of low income country, we don't have enough resources to build protocol, to build some software, to use some application for maybe if you can say a experience about everything, it's quality control also. I think if you say experience what we have done with tech and about the positive result is very important for us to learn and to avoid the mistake. Mm, I think that is.
Thank you.
So, yeah.
So for animation, I think we start because we don't have a national standard for the primary ENT and even nurses and doctors, nurses and BLS and doctors and I think we start again from international properties for the evaluations. Maybe just giving us the insight about how to build our primary school or basic ENT school because we only have nurses and most of our nurses and doctors are relatively to work outside the hospital because it's prefer to be in the hospital over outside of hospital, which is they have a different environment to work. And there's a curriculum there is not in the hospital curriculum before. So it might be better if international illness could help for the establish the education for student. And our job is try to public education is all okay, one.
For the Philippines, for example, in our bureau, so since there's our policies and guidelines are still in the works. I guess, the international community can help us guide us in making our policies on how to improve, especially we are gearing towards advancement with the law that was passed. Like in Indonesia, we don't have a paramedic, so I guess guidance as well in making our training for paramedics. But as a whole, it's really important to establish first the policies and guidelines for the EMS, the unit, the EMS, our EMS service. So I think the guidance of those who are already in the developed countries will really help us to improve our EMS.
Thank you very much. Any other questions from the audience? Okay, so if I for one last question, but I thought to just summarize what I've heard so far is that so it sounds like there is a lot of international support for the development of our emergency care system, and even at each government level, there's also policies to support it. But then does sound like that implementation is the major problem, right? And that's what we people on the ground are struggling with. So okay, let's end off with one last question. Looking towards the future. So if you could prioritize 3 policy or system level changes to improve your emergency care in your own country right now, what would it be? So it can be in terms of investment, development of EMS, but 3 top priorities areas that you'd like to work on.
So, actually, in my position, I can answer this question like I use as well. I would say if I have the power to make something to change our system, so I because new health law in Vietnam, we have a title of paramedic. So we are developed a curriculum for 2 level. First, a basic paramedic, and second is advanced paramedic. It's maybe 2 years, 4 years for training paramedic. So if I have the designation, I have to push the process faster and faster, because maybe 4 years later we have the paramedic, so it took a long time. Maybe we also my center collaborated the university in my city. We also use curriculum, maybe took 1 year more. I have the curriculum and then we use the student to learn the paramedic. So it's really 5 years. I think the health department or Ministry of Health can release some regulation to push the process faster. I think this very helpful, because nowadays we have a limited resources. We need doctor to go outside hospital, but inside in hospital we also have better resources of doctor, so we can use the doctor to go outside.
Thank you.
For my family, so first priority is to improve the 911. A standardized number that is used by all and no more each number from the local government or the private sector. It's the most important, it's one of the biggest steps to improve the EMS system. Second is the partnership. Since we are starting to improve our EMS system and we don't have the UPEC or other pre-hospital organizations. I think there should be partnerships with the Philippine College of Emergency Medicine and the Department of Health. There should be a partnership with all stakeholders to improve the EMS system. Especially we want to improve our EMS in the bureau. Next is the training. We have to enhance our personnel. Even if majority of our EMS personnel are nurses, we still need to make a curriculum to professionalize or to improve the paramedic. So we're gearing towards to having a paramedic already in the Philippines. So I think it's one priority as well.
So for my country, I think we start for the book that was launched in October 2024. Because this book is a technical guide for the whole regulation of EMS in Indonesia. So I hope the government just wants to do the monitoring of the operation of this book and also give the funding for the PSC, especially in rural area, to give their infrastructures, equipments, and actually renew different buildings. Because mostly of the ambulance in our country in rural areas is not that famous, or even they don't have anything much in the. So yeah, they need to be to be strict with the book and do the monitoring relations after 1 year after its launch.
I think one more thing I want to do is I want to have the UPEC in Singapore. Because we don't have a centralized government about the hospital care. So everything we have done first my own. I want to be left with the home. I just build my own my center. So how about the rest of center? They don't have. I also said on the but it's difficult to invest some of the different center and in different centers. So if you have one centralized about the government resource, so this center can gather on a specialist in you can see in career specialists or certain also to bring together to deeply about the idea for the phone, deeply about how to develop. I think it's very important. Because in Finland we don't have.
Thank you. Any other priority areas? The three of you. Any other areas you'd like to change in your system?
Oh, the number begin to ministry.
Yeah.
Because we have two ministry, they are both are strong one. The Ministry of Digital Communication and Ministry of Health. They're both giving 112 and 119. So they need 112 actually with police officer and then SAR and also and the 119 is only ambulance. So I think they need to be sitting together and talk about which one do you want to do as emergency management. It's quite important because right now, finally everyone using their local number because it's more available, easy, and people doesn't get confused 112 or 119.
Okay, so thank you very much. So a few common themes are here. Firstly is about having a universal access number to medical emergencies. And the issue with that, besides implementation on the ground, is also the cross-talking between the different stakeholders, right? And the second issue, which is also a priority, is about the training of the paramedics or the ambulance personnel so that we can actually provide quality care on the ambulance. To set some things in context, so the UPEC has been mentioned a few times. So that's Singapore's Unit of Pre-Hospital Emergency Care, which is under Ministry of Health. So even in Singapore, we also have the similar struggles as you guys, because the pre-hospital care comes under the Ministry of Home Affairs as well as Ministry of Health. And then you have clinician input on the care being given. That's why we have the unit of pre-hospital emergency care to bring these different stakeholders into the same room to discuss these issues and move forward. Right, so to end off, this is part of our health policy seminar series. So bringing us back to the slides that were first shared initially. So I talked about how policy making and implementation, it's two different things. And if once it's implemented, it's also important to actually follow the policy making life cycle, like what has been brought up. We need to actually evaluate if things are being done, whether it's being adopted, what are the issues with implementation, and sitting back again and re-looking if things need to be revised. So I hope you guys enjoyed this talk. Thank you very much. I'm handing over to Natasha to close it off.
Thank you so much for having me. So for the questions that were left in the chat and weren't answered, I'll compile them and send them to our speakers. And you guys are free to respond to them, and I can email the responses to attendees today. Thank you so much, everyone, for joining us. I'm just going to put up a QR code to request that everybody sends in a brief survey and thoughts about today's session, as well as any ideas that you might have for our future seminar series. And with that, I would like to thank all our speakers and also to Dr. Gayatri and Prof. Marcus for joining us today. Thank you so much.
Thank you.